A stroke is a problem that's caused by either a lack of blood flow delivery to the brain or due to bleeding into the brain itself. So people don't die of stroke as commonly nowadays, but they do require long-term care because of survival, and they survive with neurological disability. And that disability can vary from something very mild but may impair normal return to work and professional activities, or it may be quite disabling as a true handicap.
Imagine you brought the emergency department and put it on wheels in a compact fashion and brought it. Basically, when somebody calls 911 because of symptoms of stroke, the mobile stroke units act to attach to these stroke suspicious calls. And we arrive on scene with the regular 911 ambulances, and in effect, we bring a specialized stroke team, including a neurologist, a CT technologist, a paramedic, and a critical care nurse, as well as the ability to understand and distinguish between the types of stroke by scanning the patient in the field. So we also have a CT scanner on the ambulance and laboratory equipment. And after that process of diagnosing with experts and imaging comes the treatment part. That's where we expedite care. We bring that treatment to the patient as well, and we're able to treat both ischemic and hemorrhagic stroke early before taking them to the most appropriate level of stroke care. The impact on quality of life is really measurable, and also the cost analysis was done for this study called Best MSU and showed that there's healthcare cost savings. You imagine having an improved recovery, then you have less needs and to resources going forward, and being able to go back to work and be part of the family and integrate back into your normal life is really important. What we'd like to see now that we have the evidence base for both clinical improvement in patients as well as cost effectiveness, we'd like to see this available for all citizens of Los Angeles County.
This is quite precise because we're tailoring the therapies or the treatments not just based on drug A or drug B or a device. So the type of data that we deal with are clinical variables, whether the characteristics of a patient, how old they are, whether a man or a woman, whether they're presented from a certain ethnic background, what medical risk factors did they have in terms of other medical problems, and then, of course, what their imaging looks like. Whether their imaging of the stroke looks more severe or less severe, what areas are involved, what's at future risk within hours, if not minutes, from that time point. And we pair that together to provide the right decision about what drug or treatment with a device is necessary. I think the holy grail for me is figuring out how to put into practice the modern medicine of precision medicine. How do we operationalize this? How do we make this available to the largest number of patients? And this has a lot to do with the way we practice. So from a patient standpoint, that's probably what's most important. You hear very commonly, doc, please tell me, aside from the data, what do you think is best for me at this moment in time? And that's what a patient wants from the healthcare system.